Hello, I'm Mark Yeaser from the University of Pittsburgh, Southern Denmark, Tel Aviv, and I've helped out the United Nations and the European Union. And I'm really pleased to be speaking to you today in Fortaleza about how it's safe to give RHD positive blood products to all patients who you're trying to resuscitate before they get to the hospital. In particular, we'll be discussing the safety of giving Rh positive blood products to females of childbearing potential, which to my mind includes women anywhere from age of 0 until the age of 50. Here are some disclosures that I have to tell you. Of course, my main disclosure, you already know that I'm a Mengoista. I support the #1 team in Brazil, Flamengo. And of course, my team in England is called Ipswich Town, and we've just been promoted to the Premier League. So come on, Ipswich. So let's say that you're working in a helicopter or an ambulance and you've arrived on the scene of an accident and there is a patient with life-threatening bleeding in front of you, and you know you have to supply blood products to them to save their life, in particular red cells. Um, Obviously, we're going to be using group O red cells because they're compatible with every patient's naturally occurring A and B antibodies. But the problem is that there's another protein on the red cells that we're likely to be using called RHD. This protein is very immunogenic. It brings about antibody responses in many of the recipients. And the problem is that it would be really nice if we could give RHD negative group O red cells to everyone until we knew that they were either a male or a woman who is not going to have any more children. Um, but that's not really possible. Probably we're going to have to use RHD positive red cells. And the reason that it's not easy to find RHD negative red cells is that very few people themselves are RHD negative. And so if we were looking to provide RHD negative red cells, about 45% of people will be group O, about 15% will be RHD negative. And so that means only 7% of all donors who come in the blood bank to donate on this beautiful day on Ipanema Beach will be able to donate RHD negative red cells. RHD positive red cells are much easier to find. So again, half of the donors will be group O, 85% will be D positive. So now about 40% of everybody that comes in to donate will be RHD positive in group O. And these will be the red cells that we can use to resuscitate patients before they get to the hospital. And if you want to try to find Rh negative whole blood, low titer group O whole blood, it's even harder. Typically, you'll be looking for male donors to avoid the risk of immune lung injury to the recipient. Again, they have to be group O, they have to be D negative, and they have to have a low titer of anti-A and anti-B. In our center, about 93% have a low titer when the titer is below 100. When the titer is below 200, now 97% of our donors qualify as low titer. But if you multiply all of these probabilities together, you see that only 3% of everybody that walks into our blood bank is able to donate Rh negative whole blood. If we're looking for Rh positive whole blood, again, because so many more people are Rh positive compared to Rh negative, we get 6 times more donors who can donate Rh positive whole blood. Here's a lovely picture of Sao Paulo, which you might not have recognized because there isn't traffic everywhere. Haha, that's a joke. So we've said that if we give Rh positive red cells to people who are RHD negative, they might make the anti-D antibody. So some of the problems that might occur if a patient becomes de-alloimmunized is in an emergency situation, if we give an Rh positive unit to somebody who's made the anti-D antibody, they might have an immediate hemolytic reaction. but the literature tells us that in massively bleeding patients, that's unlikely to happen. It's possible they could have a future hemolytic reaction if this transfusion sensitizes them to anti-D, and then in the future, they receive an Rh positive unit. Again, in life-threatening bleeding, that's unlikely to happen. And so the biggest problem that we have is if a woman of childbearing potential who's D negative makes the anti-D antibody, she might have this hemolytic disease of the fetus and newborn problem if she becomes pregnant after her um, resuscitation with Rh positive red cells or whole blood. Just to remind you, what is hemolytic disease of the fetus and newborn? Well, here we have an RHD negative mother who's carrying an RHD positive baby, fetus, and at some point the mother gets exposed to RHD positive red cells or whole blood, and she makes the anti-D antibody, and then starting at about 20 weeks of gestation, the anti-D antibody can cross into the placenta, bind to the baby's red cells, and then destroy them. And the baby can have very severe consequences such as death, or maybe the baby might need, a fetus might need an intrauterine transfusion or an exchange transfusion, which as we'll see is uncommon when women have access to high quality antenatal health care. But this is the problem. If the mom makes the antibody, it could affect the fetus in the future. So, what is the whole context of the risk of hemolytic disease of the fetus and newborn? Well, I think that there are 8 steps, 8 slices of cheese that have to happen between the time that a woman receives an RHD positive red cell or whole blood unit during her trauma resuscitation and having the HDFN outcome. So let's go through these steps. The first step is that she has to be a woman of childbearing age. It turns out in the United States, 62% of women are between the age of 0 to 50 years old, which is the childbearing years. If a woman is older than 50, then we would no longer consider her to be childbearing. So what this means is that about 2/3 of the women that you'll see in trauma are of childbearing age, but not everyone is of childbearing age. And that's important to remember. The second event, of course, is that in order for her to develop the anti-D antibody, she has to herself be RHD negative. And so if we multiply these probabilities together, she has to be of childbearing age and RHD negative. You can see that already from the whole population of women, only 10% of women are now at risk of getting HDFN just by using 2 very basic criteria. How old is she? And does she have, or is she RHD negative? It's obviously very important for the woman to survive the trauma. If she doesn't survive the trauma, then she cannot have any future pregnancies. And luckily, about 76% of people survive their trauma. So again, accounting for the 24% of people who do not survive the trauma, from all the population of all the women, now only 77.2% of women are actually at risk of HDFN. They have to be of childbearing age, D negative, and survive the trauma. The next thing that has to happen to these women is they have to make the anti-D antibody. And it's very unclear at what rate that happens. Now, we're all taught on the first day of blood bank school that 80%, 80% of RHD negative people who receive an RHD positive unit of red cells or whole blood make anti-D. And that's true, but that 80% is based on healthy volunteers. It's not based on sick patients who are in the hospital. There have been many, many studies looking at the rate of anti-D formation in hospitalized patients. And 2 of the most recent studies are very interesting. One study found a 7.8% alloimmunization rate, and a study with a very, very similar group of patients found like a 6 times higher rate of D alloimmunization at almost 43%. My opinion is that the rate is probably about 30%. I think that's what the literature shows the most consistently. But the rate could be as high as almost 43%. So let's look at our our calculation again and see how that affects the rate of making anti-D. So let's say that 43% of RHD negative people make the anti-D antibody. That means a whole lot of people don't make the antibody. And that brings our overall rate of HDFN down to 3.1%. But it's not sufficient for her to just make the antibody. In fact, she has to make a high titer of the antibody. In our institution, the obstetricians would only start to take more close monitoring of the pregnancy if the titer of the anti-D rose to a titer of 16. Now, again, this is not the same as the titer of the anti-A and anti-B in the group O whole blood. This is the titer of the anti-D. And like I say, generally between a titer of 16 to 32 is when obstetricians would start to monitor the pregnancy more closely, maybe perform Doppler ultrasounds to check on the fetal blood flow and anemia. But again, the point here is that about 2/3 of the women make a high titer antibody, which means a third do not. And so accounting for the women who need to make the high titer antibody, now we're down to 2%. 2% of all the women are at risk of HDFN after an RHD positive during their transfusion during their resuscitation. She has to become pregnant. Obviously, if she doesn't become pregnant, then she's not at risk of hemolytic disease of the fetus and newborn. And a lot of data, at least in the US, in the United States, shows that about 86% of women will become pregnant at least one time in their life. But is this the rate? And so accounting for the 86% of women who will become pregnant, it decreases the rate of making HDFN now down to only 1.6%. So again, not every woman becomes pregnant, therefore not every woman is at risk of HDFN. But is this 86% rate of pregnancy true even in women who are involved in a trauma? With some colleagues in Finland, we studied the Finnish population, and we asked the question, what is the rate of giving birth amongst all women in Finland compared to what is the rate of giving birth to women who've had a major trauma in Finland? That's the blue line here. And you can see that women generally don't start to get pregnant in Finland until they're in their late 20s. And women in the general population usually end up with about 2 children. But if you look at the patients who've had a major trauma, you can see that the rate is much lower, maybe as much as 1/3 lower than the women in the general population. This suggests to us that that 86% rate of getting pregnant is probably too high when you consider that women in trauma tend to have a lower birth rate. But let's continue to use the 86% so that we can produce the worst case scenario estimate of HDFN. Of course, the fetus has to be RHD positive. If the fetus is RHD negative, then there will not be a risk of HDFN in the future. And accounting for the fact that at least in the American population, 40% of fetuses will be RHD negative. Now we're down to only 1%. Only 1% of women at risk of HDFN after an RHD positive transfusion during their resuscitation. It turns out that HDFN is a very treatable condition when the woman has access to high quality antenatal care. This is a very nice study from the Netherlands where they looked at all of the patients who had treatment, intrauterine transfusion treatment for HDFN. Most of this was caused by anti-D. And you can see that in the 80s and early 90s, there was about a 21% fetal mortality rate, which is very high. Okay, that's almost a quarter of the babies with HDFN die. But if you go ahead, 25 years, you can see that that fetal death rate decreases drastically to only 4%. And of course, that's a tragedy for those 4% of pregnancies that end in loss, but it's much better than it was in the 80s and early 90s. And in fact, the number of patients with severe hydrops, those are the worst cases of HDFN, was very much reduced as time went by because we became better at diagnosing and treating HDFN, in particular by being able to perform reliably intrauterine transfusions. And so hemolytic disease of the fetus and newborn is no longer the extremely fatal disease that it once was when the woman has access to high quality antenatal care. So let's consider in our calculation fetal mortality at 4%. So adding up everything that has to happen to the fetus, including dying, at a rate of 4%, you can see that the overall rate of having HDFN as a result of receiving an Rh positive transfusion during resuscitation is 0.04%. That's very, very small compared to the benefit that pre-hospital transfusions provide. And if you add in some other adverse events that might happen, such as the fetus might require intrauterine transfusion, or it might require a neonatal exchange transfusion, or sometimes fetuses have lifelong neurological sequelae after receiving an intrauterine transfusion or death. This happens in about 25% of affected pregnancies. And so if we use 25% as our fetal outcome frequency measurement, the rate goes up a little bit to 0.24%, which again, I think is quite significantly below the benefit that pre-hospital transfusions provide to our patients. That what I presented to you is a very linear model of probabilities. Here we did a computer model where we simulated thousands of injured women, and we considered her age at the time of the transfusion, the number of future pregnancies that she might expect to have, how many different partners she has, because that would affect the rate at which she's exposed to Rh positive men, and obviously the frequency of RHD in the population. And you can see that the rate of developing any degree of HDFN is about 3% when the woman is 18. And at least in the US, that drops to almost zero when she becomes 40 years of age, because very few women give birth after 40. And you can see that the risks of very severe HDFN, even at the highest risk, is about 0.5%. So in a model that includes many more factors and more probabilities, you can see that the overall rate of HDFN 3% is very low, and the rate of severe HDFN is even lower than that. This was an interesting question that was asked of us. Many of the models that we had produced only considered adult patients. So we were asked, well, what about the children? What happens if a child is injured and receives an Rh positive transfusion? And that was difficult to model because there aren't any good studies that show the rate of D alloimmunization in children, because we're so reluctant to give RHD positive products to Rh negative children. We don't know the D alloimmunization rate, but there was a very nice Japanese study of the overall alloimmunization rate in children, not just to RHD. And so we did some corrections and we ran the model again, this time using 42.7% D alloimmunization rate or 7.8%. You'll recognize these numbers as the two ends of the spectrum of D risk. And you can see that even in the worst case scenario for a woman who has the longest time to get pregnant and the most mature immune system with the highest D alloimmunization rate, the risk of HDFN, of any kind of HDFN, is about 6%. This is a very interesting model because you can ask some very interesting questions here. So what would happen, God forbid, if a 30-year-old woman is driving with her 5-year-old daughter and they get into a car crash and both the mother and the daughter arrive at your trauma hospital and you only have 1 unit of Rh positive whole blood to give? Who would you give the Rh positive whole blood unit? And I think most people would say probably give it to the child. But again, what the model shows is that the risk of future HDFN is the same because the child has a less mature immune system, but a longer time to get pregnant, whereas the 30-year-old mother has a very mature immune system, but a shorter time to get pregnant. So models can predict some very interesting long-term events. And with that, I'd like to say thank you very much and obrigado, and be happy to take any questions that you have about Rh positive transfusions during the question session. Thanks again.